Introduction. Human factors have increasingly been recognized as the source of medical errors. These can be attributed to deficiency in non-technical skills such as leadership, teamwork, and communication, which affect patient safety. Crisis resource management, originated from safety training in aviation, have been adapted to healthcare sector to guide health professionals in emergency situations, and it has been proven to improve teamwork and patient outcome. Principles of crisis resource management include knowledge of the environment, leadership, role clarity, attention allocation, workload distribution, effective communication, and use of cognitive aids. This presentation will investigate the coroner case report of Mrs. St, a 55-year-old female who dies as a result of hypoxic cerebral injury from inadvertent esophageal intubation following adverse reaction to hemodialysis. Particularly, an overview of the case report will be discussed. Concepts and principles of crisis resource management will be examined to critique the case with recommendation for future nursing practice. An overview of the case report reveals a number of deficiencies that led to Mrs. St's adverse outcome. As mentioned in the coroner case findings, Mrs. St's cerebral injury was significantly contributed to by the failure to provide oxygen in a timely manner, and although she had already been suffering breathing difficulty for about 45 minutes when she was first intubated, the misplacement of the endotracheal tube for a further 20 minutes would have greatly contributed to her hypoxic state. This is due to the failure to check ETT position using end-tidal CO2, a known gold standard for checking that end-tidal is in correct position. This is partly because Dr. D, the intensive care registrar, was not familiar that the defibrillator on the MET trolley had a CO2 monitor, and the end-tidal CO2 took additional time to warm up and calibrate. This event highlights the importance of being familiar with the equipment and environment when faced with rapidly deteriorating patient. Furthermore, Dr. D, the ICU registrar, instructed Dr. T, a junior anesthetic registrar, to intubate. Dr. T had no previous experience in emergency intubation and had not received specific training in med role. Dr. T assumed that Dr. D was a team leader, so she took on the role of airway doctor, but there was no discussion who was the most qualified to perform this emergency intubation. These indicate breakdowns in leadership and communications. Also, because it is lack of clear leadership, failure to create order, chaotic environment, and role confusion, which contribute to patients' adverse outcome. Additionally, Dr. T reported that she had to call out several times without response for the ETT to be railroaded over the bougie, and as a result she had to remove the laryngoscope to railroad the bougie herself, missing the opportunity to see the tube pass through the vocal cord. This demonstrates deficit in teamwork, coordination, and disorganized environment contributed by the lack of assertive leadership, leading to inadequate assistance provided to the anesthetic registrar. Another important key finding is that the nurses reported that they had noticed the colorimetric carbon dioxide detector, a device that provides semi-quantitative end-tidal CO2 monitoring, failed to change color, and that Mrs. St's abdomen was distending, but did not raise that concern with the doctors. This is partially due to the false reassurances by the two doctors who confirmed the placement of the tube and the nurse's failure to assertively speak up when patient safety is at risk, which result in delay in providing corrective action to reverse Mrs. St's hypoxic state. The overview of the case report highlights key concepts of crisis resource management and non-technical skills as discussed above, which include familiarity with equipment and environment, explicit identification of team leader, role clarity, clear assignment of tasks to team members, effective communication, and assertiveness in speaking up for patient safety. These concepts play critical roles in improving patient outcomes. These concepts are particularly relevant in emergency department as error rates are reported to be twice as high in this setting, given that it is a complex and high-risk environment where most clinical errors originate from human factors and teamwork due to frequent changes in team compositions. Moreover, the communication effectiveness between the interprofessional teams of doctors, nurses, and allied health staff are affected in emergency setting as they care for various patient populations with uncertainty and constraint of times and resources. Fundamental concepts of crisis resource management will be further explored in the following critique of the case. The first principles of crisis resource management to optimize patient safety is to be familiar with the work environment. This includes knowledge of the location and operation of emergency equipment, local protocols and policy, as well as the role and level of experience and capabilities of fellow staff. Lack of familiarity with the location and equipment significantly increases stress levels in crisis situations and lead to patient poor outcome. This is evident in the coroner case as the ICU registrar had not been orientated to the equipment on the Met trolley, thus he was not aware that the trolley had a CO2 monitor. Another evidence is that the junior anesthetic registrar was unprepared as she had not received training in med role and was inexperienced in emergency intubation. These contribute to delayed recognition of esophageal intubation, leading to Mrs. St hypoxic brain injury. Therefore, a working knowledge of the location and function of the critical care equipment is required to provide timely and effective intervention for safe practice. In addition, a shared understanding of members and their roles within the team is needed for appropriate task allocation based on experience level, and this helps maximize team coordinations. Designation of leadership and role clarity are key features of crisis resource management, which is required for team cohesion and collaboration. Team leader directs and coordinates activities for all team members. A good team leader supports and encourages the team, includes all members of the team. A good team leader is also calm, assertive, and inspires confidence. A clearly identifiable designated leader is required for the success of the medical emergency team. Effective communication is essential to the leadership role. Lack of leadership results in elevated stress levels, disorganized and chaotic environment, leading to detrimental consequences to the patient. As mentioned in the case report, the anesthetic registrar explained that she did not know the other doctors in the room and assumed that the ICU registrar was a team leader. There was a lack of assertive communication and clear delineation of roles, responsibility, leading to role confusion and failure to delegate tasks. This leads to uncoordinated and dysfunctional environment, putting patient at risk of severe harm. Hence, the need for clearly identifiable leader is highlighted. The team leader facilitates effective teamwork through allocating individual roles. establishing the team shared mental models of patient current status, an anticipated plan, as well as maintaining situational awareness of surrounding environment by standing back, having a big picture perspective of potential issues, and maximizing team's adaptability.
Leading a team during a stressful situation takes a careful balance between patience and assertion. The ability to quickly command attention while remaining focused and efficient takes practice, but there are some techniques that can help. First, it's important to identify yourself as the leader. This will help to clarify who should provide instruction and empower yourself into accepting the role. You may say something as simple as, "Okay, I will be leading this resuscitation." Next, identify the situation. While it may seem obvious to some, it may not always be immediately clear to everyone what's going on. In order to focus everyone's attention, it's useful to explicitly identify the situation. For example, the patient is now in cardiac arrest. Finally, identify specific roles. Clearly defined roles can help people focus on specific tasks during a stressful situation. Now, instead of feeling overwhelmed by every aspect of the situation, "Oh no, my patient is dying," a person can focus their attention in a useful way, like, "I need to place an IV." Following these 3 simple principles can help you provide better leadership during a stressful resuscitation scenario.
Furthermore, there is a lack of situational awareness as the registrar did not allocate their attention wisely and were fixated on the idea that they had successfully intubated. Also, Dr. D, the ICU registrar, failed to distribute workload appropriately and instructed Dr. T, the anesthetic registrar, to intubate, who had no previous experience in emergency intubations. This is because they did not communicate about each other's experience level. Communicating effectively and assertively is required to optimize effective teamwork. Communication is a two-way process. It is important that all team members understand what is said by others and that they are also understood. Effective communication requires clear, calm, and respectful verbal exchange of information and instructions, including non-verbal behavior such as eye contact and gesturing interactions between the leader and team members. The stress and distracting environment inherent in emergency situations can make effective communication difficult. This leads to misinformation and poor patient outcome. In the coroner case, the anesthetic registrar reported that she had to call out several times for the ETT without response. Consequently, she had to insert the ETT herself and led to accidental esophageal intubation. This is an example of communication failures, which is a leading cause of patient harm in healthcare. The physical restraint of the surrounding noise and the chaotic environment prevent the transfer of information. Closed-loop communication has been shown to reduce errors during crisis by removing ambiguity from instructions and allowing questions if the instruction was not heard clearly.
Effective communication is critical to ensure that the team works well together to achieve the best possible outcome. Communication errors are among the most common errors in resuscitations. Closed-loop communication is an effective method of communication and has been shown to reduce error rates by removing ambiguity from instructions, allowing questions if the instruction was not heard clearly, and allowing others in close proximity to be aware of the proposed course of action. Once a team leader has either requested information or asked for a procedure to be performed by a named person, that person should then acknowledge this request verbally and then confirm it when it is done. This allows for clarification of requests if needed and avoids errors of omission. Closed-loop communication allows the sender to know that their requests have been heard and understood. The use of names avoids the problem of such requests being made into an empty space. When a team leader asks out loud for a procedure to be done, unless they specify who they want to perform the procedure, then there will be a risk it will not be done at all. If possible, the team leader should use eye contact when making requests, allowing for non-verbal as well as verbal clarification. If the team names are not known, it's perfectly acceptable to address staff members by their role allocations, such as airway nurse or circulation doctor.
Assertive communication is important for patient safety. It refers to the ability to respectfully express concerns about the deficient action of others within healthcare team, and it also acts to prevent the adverse event, improve team performance, and contribute to continuous learning. On the other hand, communication breakdowns are common in healthcare. A particular problem is the failure to speak up with question or concerns which threaten patient safety and impedes learning. The nurses in the case report had noted a lack of color change on the colorimetric CO2 detector and that Mrs. St. abdomen was distending, but they did not raise their concerns with the doctors. They failed to challenge the 2 registrar confirmation of ETT2 position. Evidence in the literature indicate that authority gradient play a role in speaking up behavior, and there are several factors which contribute to authority gradient such as educational level, professional role, and perceived expertise, so that someone with less authority is less likely to challenge someone with positional power or authority to act. Subsequently, this results in clinical error which have negative impact on patient safety. It is therefore important that nurses have the skills and confidence to speak up assertively when patient safety is at risk. Suggested communication techniques that the team members can use to practice graded assertiveness is the PACE mnemonic, which P stands for probe, A stands for alert, C stands for challenge, and E stands for emergency. Or alternatively, a 5-step advocacy can be used with step 1, get attention, step 2, raise your concern, step 3, state the problem as you see it, step 4, suggest a solution, and step 5, obtain an agreement. These techniques allow anyone to challenge any actions or behavior that they think is inappropriate. Recommendations. One recommendation to apply these crisis resource management principles into practice is through simulation-based training. There is evidence that multidisciplinary simulation-based training in medical emergencies increases teamwork, leadership, and communication, which in turn promote patient safety and reduce medical error. Simulations allows participants to consolidate technical skills as well as develop non-technical skills in a realistic environment with no risk to patients and the opportunity for feedback and debrief to enhance learning. In addition, simulated scenarios help participants to become familiar with equipment, local guidelines, and policies. Therefore, simulations should be implemented in acute hospitals, particularly emergency settings, for teamwork training in addition to clinical skills. Furthermore, in the context of orientation to work environment, all staff should be familiar with the contents and location of the resuscitation equipment which services the area. Particularly, nurses have the responsibility to check and restock resuscitation trolley equipment, ensuring that they are in full working order to facilitate immediate access in emergency situations. Checking the resuscitation trolley is usually undertaken daily in accordance with the equipment checklist, and when checking is complete, checklist should be signed. Another suggestion is to use cognitive aids, including a verbal prompt, incorporating prompts for crisis resource management principles. For example, verbalizing who is the team leader, as well as steps of the resuscitation protocol, for example, reading aloud the steps of algorithm when needed. These techniques are known to improve team performance and reduce error as they provide a framework to fall back on in time-pressured situations, so team members can pay attention to other details. It is also recommended that members introduce their roles to the team on arrival at the emergency, as well as clarifying their responsibilities. It is also important that tasks are delegated to specific members to avoid role confusions, and team members should use closed-loop communication to optimize teamwork. Members should be encouraged to ask questions, check and clarify to avoid assumption. In addition, members should be empowered to speak up, implementing graded assertiveness technique, as previously discussed, to advocate for patients and escalate concerns when patient safety is compromised. Conclusion. This presentation had examined the coroner case of Mrs. St, which includes an overview of key findings and key concepts for analysis, such as failure to be familiar with the emergency equipment and environment, deficiency in leadership, communication, and lack of assertiveness of the responding MET team, resulting in Mrs. St adverse outcome. An in-depth critique of coroner case report using crisis resource management core concepts is conducted, emphasizing the importance of acquainting with the clinical environment, explicit leadership designation, role clarity, wise attention allocation, and workload distribution, effective communication, and assertive behavior. These components have critical implications for safety and quality patient care. This is particularly significant in emergency department as it is a highly complex and high-stakes environment. The recommended simulation-based training using realistic scenario has great benefit in providing participants with practice in non-technical skills. These include leadership training and communication strategy that enhance teamwork, such as closed-loop communication and graded assertiveness. Additionally, simulation allows team members to familiarize with equipment and protocols. Nurses' responsibility to check and restock resuscitation equipment is emphasized. Use of cognitive aids is also recommended for optimizing team performance. Training in crisis resource management is imperative as this minimizes human error and promotes patient safety.